I'm very conscious it's nearly 3 o'clock and it's a Friday afternoon, so if you're feeling soporific, I do understand, because connective tissue diseases may not seem that exciting. Obviously it is to me. So it's quite a broad topic that I have to sort of talk about. So I'm going to try and do it with 3 cases, and I'm hoping that, well, the first one will focus on Sjögren's, the second one I'm going to talk a bit about digital ulceration and Raynaud's and what sort of red flag features for you in primary care and when you need to think about referring in, and then finally I'm going to talk a bit about lupus and some of chronic disease management, and then a bit about the highlights of what's happening in terms of medication. So, as I said, I'm rheumatology consultant at Aintree, and I'm also digital learning editor for the British Society for Rheumatology, which I might come back to at the end because I want to see how we can support people in primary care and work with you all as well. So I've gone through this here. So first case, it's a 45-year-old lady who had a 2-year history of fatigue. She actually, so someone that I've seen in the rheumatology clinic, she gives a history of some proximal myalgia and arthralgia of the small joints. She also had a 12-month history of Raynaud's, which is sort of this classic triphasic colour change. More recently, she'd had a rash, which is very similar to the rash which is shown in that picture there, so sort of a small vessel cutaneous vasculitis, that's sort of appearance we'd say with that. And then more recently, she's had some sicker symptoms, so dry eyes, dry mouth. And then, because we can access GP records for some of the areas in Liverpool, it's really useful. I'm going to e-exchange, and you can see she had a history of submandibular swelling previously mentioned. So at this point, from what I've told you, what would be your sort of differential here? There are a couple of things here which you might think about. So just feel free to shout out. Okay, that's fine. Yeah, so Sjögren's, that would be a definite on there. She's got sicker symptoms, she's got a rash, she's got fatigue, myalgia. Rheumatoid arthritis, she describes that she's got arthralgia. You can see Raynaud's in rheumatoid as well, of course, so you can see secondary Sjögren's. Dermatomyositis, idiopathic inflammatory myositis, a bit less likely, but you could consider it. Celiac disease I put in here because although you can get actually joint pain with celiac disease, the rash is a bit different. You'll have seen this in GP, so this is dermatitis petiformis. And then the final differential, which is much less likely, would be an ANCA-positive vasculitis. And although you can see a small vessel vasculitis rash like that in GPA, Wegener's, you'll have heard of, you don't typically get sicker symptoms. So I'd be really thinking with somebody like Raynaud's or Sjögren's would be up there. So I would say you could do these investigations in primary care. You might think about doing some general blood. So full blood count's useful when you're thinking about connective tissue disease. What I mean by connective tissue disease is this sort of umbrella term which encapsulates Sjögren's, lupus, idiopathic inflammatory myositis, and then the sort of the people that don't fit into one box and they sort of are within this spectrum of disease. You might think on the full blood count, you might see a lymphopenia. You might see a raised platelets if you've got active inflammation. You sometimes see a normocytic anemia in this sort of group. Very rarely, Sjögren's can affect the kidneys, so you'd want to do your UNEs. You might see a polyclonal rise in the immunoglobulins, which is something you see obviously with inflammation. And C3, C4, if they're low, that's really helpful. That's indicative there may well be some sort of autoimmune condition. TFTs, she's got fatigue, hasn't she? A bit of arthralgia, myalgia. You need to do TFTs, part of your workup. It's not uncommon to see celiac disease in people who've got Sjögren's. So the new Sjögren's guidelines, which have come out from the BSR just in April of this year, have recommended that we do TTG testing in patients. CK, she's got myalgia. We think about vitamin D, and then I would say the last line of investigations would be more secondary care.
Why do you do the bicarb?
The bicarb is because they can get a tubular interstitial nephritis and acute tubular nephropathy with Sjögren's, and you can see abnormalities in the bicarb as part of that. So it's part of the guidelines, so just to be thinking about it, but that's more of a secondary care thing, I would say. So I just thought I'd briefly touch on immunology testing, because it's difficult to know what is appropriate to do in primary care and what should we be saving for secondary care. So an ANA, which is easy to access, has a sensitivity of 58 to 85% and specificity of 50 to 97%. So it is very unusual, but not unheard of, to have a patient who is ANA negative with a final diagnosis of Sjögren's disease. But it's very unusual. Now, if you then go on to request an ENA, what we might start to see is you might be anti-Rho, anti-LAR antibody, and that really fits with our Sjögren's potential diagnosis. However, we've been doing some work locally in our immunology lab at Liverpool, and we looked over a 3-month period. This is done by Katie Keeman, one of the clinical scientists there. For a 3-month period, 611 ANA tests requested from across primary and secondary care. 61.5% of those were negative for ANA, 376. Of those, then only 1 went on to have a potentially significant ENA result, and only 1 had a positive double-stranded DNA, but in fact it was very low and not really significant. So essentially, in summary, from looking at this, what we are looking at doing at Luft and Liverpool is, if you've got a positive ANA, then we will ask primary and secondary care, unless you're on rheumatology, not to test for ENA or double-stranded DNA. But if the ANA is positive, then the lab will automatically add on an ENA and a double-stranded DNA, because this is really encouraging sort of data to suggest that actually if you've got a negative ANA, it's highly unlikely that you're going to have a positive ENA, and it's just resource management is not the best if we do this. Also, it complicates things for people to try and interpret what does an ENA mean in the presence of a negative ANA. Choosing Wisely guidance, I think you probably all have heard of this, but this fits very much in line with what Choosing Wisely suggests. So this is an international consortium of recommendations that are made by experts across specialties, and they are very clear that you should only test for an ANA if you have a suspicion of a connective tissue disease. ANA is likely to be positive as you get older. You get a bit, your sort of immune system doesn't function as well as you get older. You're more likely to get sort of leaky cells. You produce more of these antibodies, and so you get many more false positives, which make things complicated. And also in non-rheumatic conditions, you can get positive ANAs. Now, this is the sort of thing that actually, with your different, across the country, with your different rheumatology services, advice and guidance can help be able to give advice on, so you don't necessarily refer everybody in, but rheumatology should be able to give you that sort of support to interpret if they're difficult and you're not sure what to do. So back to our patient. She had a normocytic anemia and she had low lymphocytes. Renal function LFTs were normal. She had a really strongly positive ANA, so ENA was checked and she was anti-Rho positive. You don't really see often very raised inflammatory markers in Sjögren's disease, and she had normal complements, and she did have this mildly raised polyclonal gammopathy. So anti-Rho positivity is important because A, we see it with Sjögren's disease, but secondary, it's important because she's a 45-year-old lady. She's still within that period where she is of childbearing age, and she might well be thinking about having a pregnancy at a later stage. We know that in people who are anti-Rho positive, there is placental transfer of the antibody, and you can get neonatal congenital heart block as a result. So in those people who are anti-Rho positive, we want to give them hydroxychloroquine in pregnancy. It's entirely safe. So what is Sjögren's? So we often talk about it as Sjögren's syndrome, but in the most recent guidelines, it's changed now to being called Sjögren's disease. It can be primary or secondary. So secondary, it's alongside other types of autoimmune diseases. So I've had a patient today who's got rheumatoid arthritis and got secondary Sjögren's as a result. It commonly affects women, 40 to 60 years old, and it's got a significant prevalence within the population of about 500,000. This is primary Sjögren's I'm talking about. So just as a bit of a picture, you know, it can affect the whole body. Like many of our autoimmune diseases, it's multi-system. Most typically, people have fatigue, they may well have a bit of brain fog, which they discuss, they can get, and then these arthralgias, which they describe, Raynaud's. But it's useful just to have a bit of this image in your head, because these are the ways that people might come to you in primary care, and we very much in rheumatology see people come from multiple specialties of a query of Raynaud's. So somebody from neurology has recently come to have a polyneuropathy, but they've also had submandibular swelling. So in terms of diagnosing it, anti-Ro antibodies gives you a score of 3. A focus score, which is something that you get from doing a lip biopsy, gives you a score of 3 as well. And then we can go on to do more other tests, such as a Schirmer's test, which is at the top picture there, where you look to see what the production of tears is. And then we can do salivary flow testing. In reality, we often don't need to go as far as doing many of these investigations. They're often anti-Ro positive. And if they've got very dry eyes, and you might have said a patient's optician might have said to them they've got dry eyes, their dentist might have said to them they've got a dry mouth, they've had lots of dental caries, that may well be sufficient actually to make a diagnosis. This is classification criteria, which is much more strict for clinical trial basis. So in terms of other investigations, we think about salivary gland ultrasound. That can be quite useful to look for any enlargement of the salivary glands and lymphocytic infiltration. That's got a role in diagnosis, but one of the differentials for Sjögren's is sarcoid and other connective tissue diseases, and ultrasound won't be able to differentiate, but it is useful. Particularly if somebody has been referred into secondary care who's ANA negative and got Zika symptoms, it's non-invasive. Then actually what we might think about doing is referring on for a lip biopsy. Now, depending where you are in the country, your access to this is very different. So actually, if you're in Swindon, you know, you're in a great place, because a lot of the rheumatologists will do lip biopsies for you down there. If you're in Liverpool, we've got brilliant oral medicine team, but they are very busy. So actually to get a lip biopsy can take a bit of time. So it's very much a regional thing, and we haven't got anyone trained in rheumatology to do it, but you know, this is the NHS we work in. The useful thing about doing a lip biopsy is it gives a focus score, and it can actually be more suggestive of going on to develop lymphoma, which is one of the rare long-term complications of Sjögren's. So there is some role for it other than just diagnosis. So I think you probably see a lot of Zika in general practice, because you see it as a result of drugs, you see it as people who have dry mouth from diabetes, but this is something that we just put together with the oral medicine team in Liverpool, because actually this is one of the things that for patients is most debilitating day to day if they haven't got some of the significant sequelae of Sjögren's. So having problems speaking, and just they feel really unpleasant with it. So we talk to them, and often we actually prescribe a collection of medication for them, and then we give them a bundle and say, use it, see what suits you, and then if you like it, we would ask if your GP could go on to continue prescribing. So we would often give them a spray. We would say, you know, some sugar-free chewing gum or Salivix pastels. Then we give them a gel and a mouthwash, and then you see what people's preference is. We talk about not having your room as being too dry, having a bowl of water sitting on a radiator can be quite good in the winter, so the air doesn't dry out that much. That can be helpful for the eyes as well. So we start with that approach, and then actually if this is not working, we might well refer on to oral medicine for a bit more advice, and then pilocarpine is an option as well to be started. Think about dry eyes. So a non-pharmacological approach to dry eyes is you think about warm compress for 10 minutes a day, regular long slow blinking. As you bring your eyelid down, you pull across a film across the eye, which helps reduce the dryness there. There is some evidence for oral flaxseed oil, fish oil. And then we sort of work in a tiered approach with eye drops. This is based on the Pan-Mersey guidance, which is our regional prescribing guidance here, which is excellent. But Hypermelos, Carbama, which is now back on prescribing because there was an issue with this for a while. And then Thealoz Duo, we would sort of recommend some thicker eye lubricant for night time. And then thinking about other things which could be causing dry eyes as well. If you don't ask about vaginal dryness, people won't tell you about it, and it really impacts upon people's quality of life. So you can recommend lubricant for patients, and then non-hormonal vaginal moisturisers, and then if postmenopausal, you might consider estrogen-containing treatment. So then now thinking a bit more secondary care and DMARDs, there's very limited evidence for immunosuppression in Sjögren's. Part of this is because trials have been underpowered. Patients can have wide presentation, so it's difficult to have a clean cohort. Hydroxychloroquine, though, is one of our mainstay of treatment. It can be useful for fatigue and systemic symptoms, and people have to have quite a long trial to be able to say whether it's working or not working. Some people get an inflammatory arthritis with Sjögren's, and then we might use things like methotrexate. If they've got more systemic involvement, lung disease, you might think about mycophenolate, and then very occasionally you might think about cyclophosphamide, but these are the rare, few and far between type of cases. So people with Sjögren's, their follow-up tends to be that actually if they've got fairly stable disease and mostly sicker symptoms, a bit of arthralgia, we'll probably see them every 12 months. Now, what we do is we give guidance to our patients to say that if you develop any sort of submandibular swelling, any lymph nodes which aren't going, these are sort of risk factors for lymphoma. So we would ask that they would come to us, but of course they might come to you in those time periods. So there are some risks which make you more likely to get lymphoma and some poor prognostic features. So salivary gland involvement, previous lymphadenopathy, if you have Raynaud's, ROLAR antibody positivity, monoclonal gammopathy. And you can see from looking at this, if you look at the number of risks you've got, if you've got all 7, you've got a very high, you're going to get lymphoma. So they'd be the sort of people that we may well see more than every 12 months. Other areas to consider in terms of the management is exercise is really important. There's been some evidence around Pilates. We've talked about anti-Ro positivity in pregnancy. Sjögren's charities are really important for our patients. They struggle with these symptoms quite understandably. It often affects them when they're in working age, and so actually, these patient-led charities are vital actually for supporting people day to day. So moving on to the next case. 67-year-old lady, she's come to the GP practice for a routine blood pressure check, and you notice her fingers, they look a bit dusky, and she's described that happening in the cold weather, affecting her working in a supermarket. She's not really got very significant past medical history, but of hypertension, osteoarthritis of a knee, and a previous, you could say a provoked DVT. She's had a long haul flight, and she's on bisoprolol, and she has some topical NSAIDs for her knee. So Raynaud's, primary and secondary. Primary is not when it occurs without an underlying condition, typically within people in their 20s, and it can affect 1 in 10 of the population. Secondary Raynaud's is what we're concerned about, although primary can be significant for people and sometimes needs rheumatology referral. But secondary is when it's associated with an underlying autoimmune disease. I don't know if any of you have come across on the BSR website something which has been developed within the last sort of 12, 18 months. So it's a guidance for primary care, for advice about specialist advice and when to refer, and also helps us with triage and advice that we can give back to primary care, and it's well worth looking at. So it is free to access, and if you go onto the Improving Care tab at the top, it's very useful. But it just gives you a bit of an AIDS memoir as to when to think about secondary Raynaud's, what are some of those features which might make you concerned. And really, it's going back to the principles of this secondary Raynaud's might be associated to a lupus or a systemic sclerosis or a rheumatoid. So do they have an inflammatory arthritis? Have they got mouth ulcers? Have they got features like serositis? Any of those types of things. And they're pointers. So what would be a differential at this point in this patient? So would primary Raynaud's be part of your differential? I'd say it's unlikely. She's 67, isn't she? It would be very unusual to get at this point. Psoriatic arthritis? No, there's nothing in the history to suggest that. Is that rheumatoid? Well, she's got knee osteoarthritis, but she hasn't mentioned any other joint pain, but really this is where you need a bit more history. Secondary Raynaud's would definitely be up there. Sjögren's, she doesn't mention sicker symptoms, I don't think, from the history, but it's part of it, secondary Raynaud's. And then systemic sclerosis. So what would you suggest to her at this point? So I'm going to get her to stop smoking, or ask her to. You'll refer to rheumatology. Now, you could request, I put ANA and ENA, but you're going to request an ANA, and then what you might think is if it's positive, it will go on to be reflexed into an ENA. And this depends on where you work in the country. And CCP, rheumatoid factor, inflammatory markers, because it could be secondary Raynaud's from a rheumatoid arthritis, if she's had some arthralgia. And then she's on bisoprolol. So actually, this could be worsening her peripheral vasoconstriction. So if you think it's feasible, I would recommend that you might consider switching her to a calcium channel blocker like nifedipine. Now, you wouldn't start methotrexate, of course, in primary care, but actually there's no indication to start at this point. She hasn't got any features of an inflammatory arthritis. She's just got Raynaud's. And then you could ask her to get some silver gloves, which are on Amazon for £10. We can get them in hospital otherwise, but they're a fine mesh glove. Often people get heated USB packs, and they're really nice as gloves, like heated gloves, which are really nice as sort of helpful with quite problematic Raynaud's. So then she comes to rheumatology, and we do nail fold capillaroscopy. I don't know if anyone's ever come across this as a test. It's a really nice investigation that we can do as the patient's sitting with us. So by looking at the nails, the capillaries run parallel to the nail fold, and you can do it with a dermatoscope, but with a USB microscope, you can have a look in a bit more detail, and if there's abnormalities in the nail fold capillaries, it's more suggestive this is a secondary Raynaud's. So this is one of the abnormalities you might see in systemic sclerosis. So you might get a giant capillary. This is what you might see, some enlarged capillaries. And then these are normal capillaries, look a bit like Kirby grips, you know, at the top of the page. So you may well not have a full house of symptoms and signs, but when we look at them in clinic, it gives us a sense of, if they don't tick a box for systemic sclerosis at this point, their Raynaud's is suspicious. They may well go on to develop an autoimmune connective tissue disease, so we want to keep an eye on them. So this lady's blood's returned, and she's positive ANA, and she's anti-centromere antibody positive, which you see with systemic sclerosis. And she also reports some tightening of her fingers, and she's got a really sore finger. So this is just some images of digital ulcers, which I took from some patients over the last year or so. They tend to be extremely painful. There isn't always a history of trauma, when they may well have underlying calcinosis underneath them. And because of the tight skin, it makes it more likely that the skin can rupture. And if somebody has that, we really want to know about it in terms of how we triage our referrals. They're at high risk for infection. If they start to look infected, they will need antibiotics, but then they can go on to develop osteomyelitis. So if they're not improving, we also want to know about them with a course of flucloxacillin, for example. So this lady actually meets a diagnosis for criteria for systemic sclerosis. She's got digital ulcers, she's had abnormal nail fold capillaries, Raynaud's, and she's got anti-centromere antibody positive. So in terms of how we manage secondary Raynaud's and digital ulcers, we start off in a lot of ladder approach with a calcium channel blocker. We often start low with this, and this can be done in primary care, and I quite often give 10 milligrams BD, modified release, and then as the patient gets used to it, I ask them to titrate it up to maximum sort of 30 milligrams BD. Increasingly, we're using sildenafil and tadalafil. I don't know how much you've seen of that with people in secondary care. It used to be very expensive, it's not anymore, so we're using it a lot more. And people do get headaches sometimes, but actually we quite often start it in a staggered way on a low dose, and then people can build up a tolerance and manage it. Benson is an endothelin receptor antagonist, which has got good evidence to show that it reduces the formation of new digital ulcers. It doesn't necessarily speed up healing when you've got them, but stops new ones happening. So you try to maximise the vasodilatation of the vessels, and then you're trying to give something else to try and stop the ulcers developing. And if they've got multiple ulcers, they might need iloprost, which is an intravenous infusion to try and open up the blood vessels. And you might think about a digital ulcer causing osteomyelitis. So, I'm just conscious of time, I'm moving quite swiftly through it, but I've got one more case. So, third lady, 35-year-old, her background history is she's had lupus. She had an episode of pericarditis, an inpatient stay, and it led to this diagnosis. She was ANA positive, Rho positive, and anti-Smith positive. So, when we think about lupus, this is now trying to have a bit more of a bird's eye view rather than focus on the ins and outs of her diagnosis. Our general approach is we think about disease activity, how we can escalate management to try and aim for remission and low disease activity on the minimum amount of immunomodulatory therapy. We want to mitigate the risks of medication and chronic disease. And we are trying to give people less than 5 milligrams per kilogram of hydroxychloroquine, because higher than that dose increases your risk of retinal toxicity. And then we try to aim for a dose of less than 5 milligrams per day of prednisolone. And I start with this because I do sometimes wonder how many people there are with a long-standing history of diagnosis of lupus within the community who may have got lost to follow-up and be sitting around on probably 8-10 milligrams of prednisolone, which have got unacceptable side effect risks. And actually we've got really good drugs now compared to what we had 10 years ago, or many better drugs than we had. So this is just quite a nice picture really describing what I've just said to you about how we approach our management. I guess the other key thing actually on that slide to point out is on the left side or the right side, the general measures that are really important that we don't always give as much weight to that we should do in clinic, about sun protection. So we have to get our patients to wear factor 50 sun cream because actually just being in the sunshine increases your risk of a lupus flare. And as a result of that, they may well be vitamin D deficient, so it's important to think about that as another cause for arthralgia. Just re-emphasise the importance of exercise, not smoking, vaccinations, which I'll come back to in a minute, are really important in thinking about the sort of collective picture of our patients. So I'm just going to talk through a couple of management areas which I wonder if you may see a bit of in primary care. So one is contraception and reproduction. So typically women of childbearing age have lupus, it's very common, or we may see lupus in people who've been diagnosed in the paediatric population who then transition over to adult care. So we try and talk about contraception and family planning at lots of appointments, so that because people's changed their minds and their decision and we want it to be present in terms of thinking about our treatment. So we know that active lupus is a strong predictor of poor outcomes for the mother and baby. So we really aim for quiescent disease for at least 6 months on a medication which is compatible with pregnancy. So if somebody with lupus comes to you and they say, I'm thinking about having a family, and they haven't been seen by rheumatology for a bit of time, I would suggest that either you write to us, you ask the patient to contact the rheumatologist to say, I'm thinking I'd like a baby, because they might be on mycophenolate, and then we need, which is teratogenic, we need to switch them over to azathioprine and make sure they're stable, and then ask them to think about trying to conceive. We also like to think about or recheck for their anti-Rolar antibodies. I've talked about anti-Ro before and the risk of congenital heart block. We recheck their antiphospholipid screen because if they're antiphospholipid antibody positive, they've got increased risk of small gestational age, placental insufficiency, clots within pregnancy. And it guides us as to what sort of medicate, whether we give them aspirin in pregnancy or whether we give them low molecular weight heparin. Hydroxychloroquine is really safe in pregnancy and it reduces lupus flares, so if somebody's not on it, we really want to make sure that they're on that before they start to try and conceive. And if they've already conceived, we want to know about it really fast so we can put them on hydroxychloroquine. So in terms of thinking about contraception now, with people that have got lupus and other connective tissue diseases, we've been now, what I would say is important is, and some of this is secondary care as opposed to primary, but I want to, I thought it would be useful just to mention it because people will come to you and ask them about contraception, is thinking about their antiphospholipid status. So essentially, if they've got an antiphospholipid, if they are positive antiphospholipid antibodies, you want to be avoiding estrogen, progesterone, contraceptive pills. So in these sort of people, we really recommend the coil. It's just really nice because you know that if they've got the copper coil in situ or a marina coil, that actually they're not going to fall pregnant unless you take it out, and then it can be a planned pregnancy. So we are increasingly asking for our patients, particularly if they're starting things like mycophenolate, to have long-acting contraception. We've recently, with our, in the region, have set up access to our local sexual health service so that people can get, if not on the day, contraception within a week contraception, so that we've had a case of a pregnancy with between the time of somebody being started on mycophenolate and then waiting to get their coil fitted, falling pregnant, which is really sort of an event that you don't want to happen for anyone in the situation. So this has come as a result of that. Menopause and HRT, I mean, you will know much more about menopause than I do and HRT. There's not a great deal of evidence about it. I think within the rheumatology community it's starting to be discussed a bit more. We had a couple of really good lectures at the BSR about it this year. There has been concern in the past that actually if you've got lupus and you start on HRT, it can cause a flare of your symptoms of HRT. I think that there is some discussion that that may not be the case actually. And so there is varying guidance which is out there. So if you go onto Lupus UK, it recommends that you might not think about starting HRT, but discuss it with your clinician. Now actually there is some good guidance from EULAR, which actually says that if you've had no significant flares in 12 to 24 months, you've got fairly mild lupus, you've got really difficult symptoms of menopause and affecting quality of life, actually HRT might be okay to use in that sort of situation. So I guess my message on this is it's not a definite no, and if you're not sure, speak to the consultant rheumatologist that's looking after the patient and we can provide some advice. And I have started people with lupus on this. In primary care, you're excellent at managing chronic disease, and I think we've got a lot to learn from that in secondary care. We know that actually one of the main reasons people die now of lupus is they're living a lot longer with the disease and they're developing significant cardiovascular disease as a result, or through having an active inflammatory condition, but also from some of the medications such as steroids. They've got similar risks to what we see in rheumatoid arthritis and what we see within diabetes, and actually probably higher. They have a higher risk of stroke as well. Actually, our risk assessment scores can often underestimate their cardiovascular risk because they quite often have a low BMI. So you need to have a high threshold of suspicion for thinking about this in patients. The European guidance recommends you do the SCORE algorithm to look at cardiovascular disease. We quite often use QRisk3, which is what you use for assessing it, and now it's got a box that you can tick, hasn't it, for lupus on it. So it's just important to have that in mind because my understanding is they wouldn't fall under your KPIs, is that right, for a patient with lupus, so thinking about cardiovascular disease. So we should be doing that in hospital, but we miss things. So as with all the general care of this patient together, it's helpful if you see this as well. You want to aim to lower disease activity, and that improves cardiovascular disease. We want to aim for a lower BP, lowest possible steroid dose, and we know that hydroxychloroquine reduces the risk of cardiovascular events. So actually, someone who's had lupus for many years and is really stable with mild disease, we might get them off all their immunosuppression, but just leave them on a bit of hydroxychloroquine because it reduces their risk of relapse and reduces their cardiovascular risk, and it's very safe. The only risk is of retinal toxicity, and then after 5 years, they'll be screened as part of a screening programme that will happen yearly. If they've got lupus nephritis, you might want to think about the addition of an ACE inhibitor or an ARB. They'll be under a renal team, but just for you to be aware of that. Statins are used in line with the general population, and you know this, thinking about when to give a torvastatin, but I don't think it's always been at the forefront of our minds in the management of these sorts of diseases as rheumatologists. Bone protection, important to think about FRAX within this group, and it can underestimate people who have been on prednisolone for greater than 7.5 milligrams for more than 3 months. So it may well be, if someone's had a flare of lupus, we might well have given them a treatment course of steroid for 3 months, slowly reducing. And if they've had that happen consistently over a few years, their actual risk of osteoporosis may be less than we would initially think. So it's just important to bear that in mind and not be too slow to request a DEXA. And think about vitamin D deficiency. So it's a bit small, this slide, but essentially, vaccinations, just wanted to touch on as well. So, flu vaccine, we should be giving a seasonal flu vaccine to all patients with lupus. Pneumococcal is actually a bit more varied across where you look at your guidelines. So I've recently had a 40-year-old really sick lupus patient who's had an invasive pneumococcal infection, went on to get HLH, and she'd had a pneumococcal vaccine 8 years ago. And there is good evidence to show that actually if you have got lupus, you have a 13 times higher risk of invasive pneumococcal infection. So If you look at the American guidelines, they suggest that anyone with an autoimmune rheumatic disease under the age of 65 on immunosuppression should have Pneumovax. If you look at EULAR, they also should have Pneumovax and then have a booster at 5 years. And so if my patient had had that and a booster at 5 years, she may well not have got this significant pneumococcal bacteremia which she had. In the UK, our guidance, the Green Book advice, is that antibodies start to wane after 5 years, and if they've got chronic renal disease or under a significant amount of immunosuppression, then we might think about giving them a booster. But actually, some of our patients don't have that, so don't fall into that category. So I guess we go by UK guidance, but this is an area that I'm thinking about more, is when do I recommend a booster for my patients who've got lupus and may well have over time had quite a bit of immunosuppression, which doesn't necessarily quite fit the guidelines, but a pneumococcal vaccination is probably not going to cause a great deal of problem for them, but actually might reduce them going on to get a significant life-threatening illness. You don't want to base your medicine on anecdote, but it does make you think sometimes. There's new BSR lupus guidance that's coming out next year, and I think that it would be really interesting to see what they say as a UK consensus on that. HPV and vaccinations, they have an increased risk of cervical dysplasia, vaginal and vulval cancer, and we need to make sure that we offer HPV vaccine to young women with stable inactive disease. And it's tricky, this population, because they're in and out of hospital, they're often seeing multiple specialties, they're at a time in their life when they're obviously wanting to get on with a job, they're young, they want a family, they're spending much more time in medical care than they want, and then we want to try and do these more, these tasks which might seem a bit more mundane, but actually vaccinations are really crucial to try and prevent illness. So how we interact with this population group is hard, and it's a constant challenge. So finally, I'm not going to talk about immunology. This is just to give you a bit of a picture to show you that in what we had for lupus in terms of treatment in sort of the last 10 years is very different to what we had 20 years ago, and the treatment trajectory is looking very much better, and it's exciting really. In the past, thinking about, I won't talk about immunology much, except to say that in the past a lot of our treatment focused on B cells, and actually we think that for some people who've got really difficult to treat lupus, it's because their disease works in a different way, and it may well be that it's based on more T cells and B cells as well, so we can block off the B cells but they still have active rash. But there's drugs which are coming along, things like anifrolumab, which focus on interferon and T cells and seem to be getting rid of really severe cutaneous lupus for these patients, and it's a bit of a game changer. So it's licensed in America and in Europe, and NICE have said no initially, and I suspect that probably on the repeated submission to NICE they may well say yes. But there's other good drugs as well which are coming on board. So belimumab is a really nice drug which is well tolerated, which we're using more and more. The other thing is dapagliflozin, or dapagliflozin, however you say it. There's trials which are coming out looking about its role in lupus nephritis, which is quite exciting. I mean, this drug seems to be just very good generally, doesn't it? So we'll see if it comes into our lupus sort of prescribing armamentarium. Deucravacitinib is another drug which is interesting. So it's had license in psoriasis, and then there's phase 3 trials which are going on in lupus. So it's a bit like, you've probably heard of JAK inhibitors for rheumatoid arthritis. So it works on similar pathways to JAK inhibitors. So we'll look to see what goes on with that. So we're in a much better place than we were essentially. So that's a bit of a whistle-stop tour over Sjögren's, digital ulceration and Raynaud's, and chronic disease management in lupus. But hopefully that will have piqued your interest a bit, and I'm happy to answer questions. And then I thought finally I would just do a very quick slide just to show you what my other hat is as a digital learning editor for BSR. And we produce quite a lot of podcasts which are very well received. They're on all of your normal podcast streaming platforms, Spotify, Apple, Deezer, whatever it might be. They're all free, obviously. We've got 50,000 downloads, so they're for the MDT, and there are topics which I think would be perhaps of more interest to you, but we often have a conversation with an expert. There's some on quality improvement and exciting QI projects in rheumatology, lots of different things. So it's worth a listen if you have a commute. You might find it good. And then in terms of other things which are available, and I'd be really interested to see how we can look better at helping work together and sort of think about primary care, is things like osteoporosis, and we do e-learning modules, and which can be very good as well. So I think that it's really important as we look at the interface between primary and secondary care that we work to try and support each other's, because we both have got great pressures, haven't we, within the way that we're working, and we don't want to duplicate things, but we want to make sure that what we do is supportive, and it doesn't feel like we're saying, can you do chronic disease management, because that actually should really be what we do within secondary care as well, but how do we best work? And I'd be really interested to hear what you thought about that, and if you've got any questions.
Thank you. Thank you very much. Just to say quickly, we do work with Daisy Southern.
Yes, I know.
Chris and I.
Yeah.
I've had so she's the education lead for BSR.
Yeah, which is fantastic.
Yeah. It does seem that some of this digital stuff is going on as well that we're not as aware of.
Yeah, well, that's what I wondered, and because I work with Daisy,
yes.
very closely, and we wonder whether or not there's things that we can work together on to see how we can best support in terms of developing resources, because sometimes we can be very secondary care focused, and we're conscious with first contact practitioners coming as well. We need to make sure that we're recognising the rheumatology MSK team is broader.
Yeah, yes. So we've said the same, so it'd be good to work together. Yeah. Any questions? Chris.
Thank you. Very interesting talk. Primary care on Monday was hit with RSV vaccinations this October, likely to be the same as the pneumococcal population.
Right.
Are you aware of it? Have you considered it?
No.
Yep. The Green Book is still 10 years out of date, by the way, as of Tuesday.
Right, okay, well that's helpful to know, because when you read it, it doesn't always seem as up-to-date as you would imagine. No, I didn't know that, and that's really useful, so I will take that back to my department and see what we've got planned for that. Thank you.
So is that for children and adults?
Oh, yes.
Because I didn't read the small print. Okay.
Thank you. I would be interested to find out what was the patient's occupation in the second case with Raynaud's. Was she a dentist or orthopedic surgeon?
Oh, are you talking about sort of because of using vibratory tools? No, she wasn't. And actually that's something why nail fold capillaroscopy is quite helpful. So actually Raynaud's, due to vibratory tools, is a secondary cause of Raynaud's, but it's not a type of Raynaud's which is associated with an autoimmune disease. So you would expect on your panel of bloods them to have negative serology or immunology testing, and then when you do nail fold capillaroscopy you would expect it to be normal as well. So she didn't, but I do see people in my clinic who have been road workers and use pneumatic drills, or they've worked in factories. We've got quite a few big car making factories over on the Wirral and other bits of Liverpool, and occupation's a really important part. What's interesting actually is how much more occupational health within some of these big firms seem to be aware of it. So a recent person I had was telling me how the drill that he uses now has got some sort of attachment which sits on it, which means that it can only get to a certain number of, I don't know if it's hertz, I can't remember the value that they use to assess the power, but it can only get to a certain level because he's got early stages of vibratory complications.
Vibration magnitude, and would your list of differential diagnosis included halves if the patient was...
Yes. Oh, well, and yeah, I mean, if the occupation had been suggestive of that, yes, definitely. So yes, if you do see someone and you're suspicious as a GP, please make sure you highlight that in the referral that comes to us. But we should be asking that in secondary care.
And in terms of treatment, what else would you include in the options?
For somebody...
For house, yes.
A lot of it is going back to thinking about what their occupation is, how can their occupation be modified, if it can be. If they're getting a lot of vasoconstriction symptoms, you might think about nifedipine for that, but my understanding is there's not a great much more that we would offer. Sometimes they can get nerve entrapment issues as well, so you might think about doing carpal tunnel, checking for carpal tunnel syndrome, and sometimes we do refer on to hand surgeons as well to see if there's anything more that they can offer, but trying to avoid what the precursor is if you can as well, is what's caused it is useful.